Fundamentals 1, the back and vertebral column. Here are the lecture objectives for today. You will see that these are identical with the objectives listed on your instructional topic template, which you should definitely study before class. Here's the outline for today's lecture. We will first be dealing with the structure and functions of the vertebral column, head over to the spinal cord and its coverings, have a look at how the nerves relate to the individual vertebrae, study the ligaments in the joints. We're going to have a look at some of the intervertebral discs. We will see if there are differences in the regional characteristics of the different vertebrae. And as this is indeed the case, we will then study briefly the thoracic region, the lumbar region. We'll have a look at some clinical presentations. We'll have a look at the sacrum, the coccyx, and then last but not least, we will have a look at the arterial supply of the spinal cord. If we have a look at the structure of the vertebral column, we can see that the vertebral column, as its function is to support our body weight, the size of the vertebrae will increase from C1 down to L5, so that supports the increasing body weight from the head down to the sacrum. We have 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, and 3 to 4 coccygeal. Note please that the sacral vertebrae down here are fused, as are the coccygeal vertebrae. So in total we will end up having 32 to 33 vertebrae. Of these, the first 24, so the presacral ones, are all movable. The vertebral column will permit movement of the trunk. The movements would be flexion and extension, as you can see depicted under A, so in the sagittal plane. If you think about bending sideways, that is called lateral extension, so that is actually movement in the coronal plane. Or you would also have movement which is rotational, if you just turn your upper body and have your lower limb planted firmly on the ground. An additional function of the vertebral column is to protect the spinal cord. The spinal cord, as we can see right here, actually has 3 different membranes that surround it. It has a very tough outer layer, the dura mater, which stands for tough mother. Then there's a spider web-like layer called the arachnoid mater, and then last but not least, the pia mater. The pia mater is actually a layer that you cannot remove from the spinal cord, is firmly adhered to it. The other 2 layers actually, although they are pushed against each other in vivo, those are distinct layers. Okay, and so then if we have a look at the spaces that are generated, these are true or just potential spaces. If we have a look at the space that would be above the dura, we will call it the epidural space, which is between the dura itself and the periosteum of the vertebrae. Within here we can find some fat and a few veins of the vertebral venous plexus, and inferior to the level of L2 we can find some roots of the spinal nerves. On the other hand, if we have a look at the subarachnoid space, which as the name indicates is deep to the arachnoid mater, within here is very important, we can find CSF, so cerebrospinal fluid, and we can find several different types of arteries and veins. One thing to consider when we look at the spinal cord is that we can subdivide this according to the color coding here into different nerves and ganglia. We have the cervical, we have the thoracic, the lumbar, and a little bit here of the sacral and coccygeal nerves and associated ganglia. You also see that you have these 2 enlargements. There's a cervical enlargement and a lumbar enlargement, and the reason that we have these enlargements is that we have arms and legs, and the cervical and lumbar enlargements, those are the areas from where our brachial plexus in case of the arms and our lumbar plexus in case of the lower limbs, this is where they receive their motor neurons from, for instance. Another thing that you're going to see is that the spinal cord actually, although it starts all the way from the occipital bone, it goes just all the way down to about L2 here. That's where it ends. So there's no more spinal cord there, but there are lots of spinal nerves still down here. And it's important to know this because for lumbar punctures, you can pretty safely perform a lumbar puncture inferior to the termination of the spinal cord, so inferior to L2. Next, there's an important thing to know about the relationship of the spinal nerves to the vertebrae. Okay, if we start off right here, here's our skull, here's the C1 vertebrae, and the name of the C1 vertebrae is Atlas, who was in Greek mythology the person who was holding the whole world, so must have been a pretty strong man. The C1 nerve will emerge between the skull and atlas. A little further down, this is going to be different because we have a transition in the nomenclature. Okay, the C8 nerve is not going to emerge above, it's going to emerge below the C7 vertebrae. Okay, and then we also have the T1 nerve emerge below the T1 vertebrae. So instead of emerging above the vertebrae, like C1, 2, 3, 4, 5, 6, 7, C8 is going to emerge above the T1 vertebra, but below the C7, and then the T1 nerve is going to emerge below the T1 vertebrae, T2 is going to emerge below T2, T3 below T3, and so on and so forth for the rest of the extent of the spinal cord. So if we now have a look at some of the curvatures that we can see in our vertebral column, so the embryo actually, due to the folding that occurs, first actually starts off as a C shape, and then later on additional folding will lead to kyphoses, which are anteriorly concave primary curvatures. They will persist and become more pronounced throughout life. The kyphoses exist in the thoracic region and in the sacral regions. Then in addition to that, you also have posteriorly concave secondary curvatures, which are called lordoses. You have one in the cervical region and one in the lumbar region. The lordoses first will develop in the cervical region. The reason that the lordoses first develop in the cervical region is due to the fact that the infant has to learn to control its head when it actually starts crawling and then walking later on, and then later the lordoses develops in the lumbar region. Also, an advantage of these secondary curvatures is that it allows the line of gravity to fall along the line of the vertebral column, which helps us require much less energy expenditure to stand and also to walk. We also have abnormal curvatures. If we have an excessive curvature in the thoracic region, this is called a kyphosis, or an excessive curvature in the lumbar region is called lordoses. We also have a sideways leaning of the vertebral column. This is actually called scoliosis, or crooked or curved back. So what you see here occurring is a lateral bending and also a rotation of the vertebral column, which will lead to a rib hump during the flexion of the trunk. And this can either be due to bad posture. You probably often see people that are sitting slouched over or just not having a very good body posture. In that case it might be reversible, but it can also be structural. That means it can be due to anomalous vertebrae or differential length of the lower extremities. Here's an example of the kyphoses, a very excessive kyphoses. Here's how Walt Disney sees kyphoses. And here is an example of scolioses. So now let's have a look at the components of a typical vertebrae. The anterior portion here is the vertebral body. This is a pretty massive portion of it, and it's actually the one that's responsible for transmitting the body weight. It has an inner zone here, which is the spongy or trabecular part of the bone, and it's surrounded by a rather thin layer of compact bone. The body of the vertebrae, if you think of it in a top to bottom fashion, are held together by intervertebral discs, which are made up of fibrocartilage and ligaments, as we're going to see soon. Next, there's the vertebral arch, here in red. These are all the elements that are posterior to the body of the vertebrae, and they're also the ones that encase the spinal cord. These regions, although not labeled in this slide, these are called pedicles. These are these very short and stout processes that will join the vertebral arch to the body of the vertebrae. And these pedicles will join to these regions here, which are called lamina. And the lamina are these two broad and rather flat pieces of bone that form the posterior part of the vertebral foramina. And then we also have several bony processes that arise from the arch of the vertebrae. Usually from a typical vertebrae it's about 7. We have, for instance, the spinous process. We have 1 per vertebrae, which is responsible for muscle attachment. The transverse processes are also responsible for muscle attachment. There are 2. There's 1 on the left and 1 on the right side. There are these articular processes. There are 4 of them on each vertebrae. These are the processes that will actually help 2 vertebrae to interlock into each other. And so they will arise from these regions, which are the junctions of the pedicles and the lamina. The joints that they form are called zygapophyseal, or easily facet joints. If we have a look at 2 adjoining vertebrae from a lateral aspect, we can see that there's a hole in between them. This hole is called the intervertebral foramen because it's between a superior and inferior vertebra. These foramina are very important because they create the passageways by which spinal nerves are going to exit the vertebral canal. Okay? Each IV foramen is going to be formed by the inferior notch on the superior vertebrae and the superior vertebral notch on the inferior vertebrae, and in addition to that, the intervertebral disc between them. If we consider the boundaries of the intervertebral foramen, anteriorly and superiorly, you're going to have the body of the superior vertebrae, as you can see right here. Anteriorly and inferiorly, you're going to have the IV disc. Superiorly and inferiorly are going to be the pedicles of the adjoining superior and inferior vertebrae. Behind them, so posteriorly, you're going to have the posterior, superior, and inferior articular processes with these zygapophyseal or just facet joints that are formed in between them. It might be a good idea to mention that the spinal nerves in the lumbar region will actually increase in size from above, so from L1 down to L5. Although the size of the foramina will decrease in caliber, so you have increasing sizes of spinal nerves that are passing through smaller and smaller foramina. So the 5th lumbar root is going to be the thickest one, passing through the narrowest foramina you can have. Spinal nerves usually exit in the superior part of the IV foramen, behind or posterior to the vertebral body, not posterior to the disc. This is why if a disc herniates, it's usually going to affect the nerve that is going to travel to the IV foramen on the level below. It won't affect the nerve that is exiting at the same level as the disc. Now, if we want to have a look at the internal aspect of the vertebral bodies and the vertebral canal, we can get a better appreciation of the ligaments that are involved in this as well. Highlighted here in red is the anterior longitudinal ligament, which is a fibrous band that goes along the entire anterior surface of the vertebral bodies, and also, of course, the associated IV discs. Yeah. What it does is actually it traverses from the pelvic surface all the way onto the sacrum to the anterior tubercle of C1, yeah, so including the occipital bone, but it'll limit the extension of the vertebral column. Where there is an anterior ligament, there better be a posterior one as well, just as you know if there's something superior, there's something inferior, and if there's something major, there's going to be something minor. So here's your posterior longitudinal ligament. The posterior longitudinal ligament is not as wide and not as strong as the anterior one. Imagine you're looking at the anterior aspect, the bodies of the vertebrae are pretty wide anteriorly, but on the posterior aspect within the canal, you only have a thin strip. Okay, so this will run the length of the canal as well, yeah, all the way from C2 down to the sacrum, but this here is not as strong as I said, and its role is to prevent the hyperflexion of the vertebral column. Okay, and as it actually crosses all over and connects the bodies of the vertebrae together here from the posterior aspect, the intervertebral disc cannot herniate posteriorly. Then we have here the ligamentum flavum, which is yellow, hence the name. They cover the lamina of the vertebral canal, and they are important to protect the IV discs during sudden flexion of the column. They also assist with straightening the back after flexion. As a memory device to remember which one's the ligamentum flavum, Just think of ligamentum flava-flav. Last but not least, the intervertebral disc. The disc has two parts. It has this inner part, which is called the nucleus pulposus. It's a remnant of an embryological structure, which is called the notochord, and it has an outer part, which is this fibrous portion. It's called the annulus fibrosus, which in a direct translation would translate to something like the fibrous ring, which is exactly what it is. If we now look at this from an anterior view, we can see the anterior longitudinal ligament, and this here will cover all of the anterior aspect and a little bit of the lateral aspect of the bodies of the vertebrae and the discs, of course, in between the vertebrae. And let's recall again that this is the ligament that helps you resist hyperextension, like that is, for instance, an injury that you would occur in a rear car crash, which would be a whiplash trauma. And you can also see very nicely here in this view, if we have a look at the inside of the vertebral canal, lying right here, this narrow little band here, this is your posterior longitudinal ligament. This ligament will be running on the posterior aspect here of the vertebral bodies, in between the pedicles, which have been cut here, and it widens every time. We can't see it in this picture, but it widens every time when it blends with the IV discs at every level. And it helps in resisting hyperflexion. And then again we have here our ligamentum flavum. This is the ligament that connects the adjacent laminae. So as I mentioned earlier, the name of the joints of the vertebral arches is zygapophyseal joint, or just simply facet. It is, in terms of joints, it is a plain type of synovial joint, and is not weight-bearing. Interesting here, as we have the interlocking facets of the inferior articular process and the superior articular process from the participating vertebrae, as in most joints there is a joint capsule, and the orientation and the shape of these facets is going to be the determining factor in what kind of movement is going to be permitted. And also noteworthy about these joints is that the transition from the thoracic to the lumbar region is actually quite abrupt. It occurs at the T12 vertebrae. Here we have a good overview of the accessory ligaments of the vertebral column again. First off, the ligamenta flava, as you can see here, joining the laminae of adjacent vertebrae. Remember that the ligamenta flava, as they assist in straightening the vertebral column after flexion, they can also be regarded as muscle savers, so they're elastic, like little rubber bands. Then there are these interspinous ligaments here. They will, as the name suggests, they are in between the spines of the vertebrae. And then there's the supraspinous ligament, which is actually a really strong ligament. It then blends with this ligament here, which is called the nuchal ligament. It's a strong and pretty broad median ligament, and it will provide attachment for some of the muscles in the back of the neck. Another thing that we need to remember concerning the spinal cord is that the spinal cord does not actually extend the entire length of the vertebral column. It usually ends between L1 and L2 somewhere in this little tapering called the conus medullaris. So below L2 then, you're only going to have the roots of the lower spinal nerves, no more spinal cord. And as this looks kind of like a horse's tail, it's called the cauda equina. And these spinal nerves will then exit through their respective foramina. We can take advantage of this when we're performing a lumbar puncture. If we have a look at the picture here, the posterior aspect of this man's back, we can see as a landmark, the first thing, you can see these little dimples here. Those dimples are at approximately the level of S2. Those indicate the location of the posterior superior iliac spines. This line here indicates the level of the L4-5 IV disc, so a little higher up would still be a safe area to perform a lumbar puncture. So the layers traversed in order would be skin, fat and whatever subcutaneous tissue there is, the supraspinous ligament, the interspinous ligaments, the ligamentum flavum, the dura and arachnoid together, and then we would end up in the lumbar cistern that contains CSF. Here's a little clinical correlation for us about a hyperextension or whiplash injury. This can occur during a motor vehicle crash where you are rear-ended and you do not have a headrest. This is very dangerous. You see how the head gets whipped backwards here. And as indicated in this picture, this can actually lead to a stretching or even tearing of the anterior longitudinal ligament. Because the ALL is the only ligament that will resist hyperextension. All the other ligaments of the vertebral column will resist forms of flexion. If you have severe hyperextension of the neck, as indicated through this tackle here, again it may lead also to a tearing of the anterior longitudinal ligament, but you also might suffer a so-called hangman's fracture, which is actually a type of fracture where you have a separation of the head, C1, and the dens and the body of C2 from the rest of the axial skeleton. As you can imagine, this can be absolutely devastating and also fatal if the spinal cord is severed. One more look at the intervertebral discs. So the discs hold the vertebrae together, the adjacent vertebrae here. We'll refer to the joints that they create as symphyses. And as I mentioned before, they consist of this outer fibrous ring and this inner kind of squishy mass called the nucleus pulposus. This is made of water to a very high degree. And interestingly, about 25% of the height of the vertebral column is solely due to the thickness of the intervertebral disc. Interestingly, on the posterior aspect, the annulus fibrosus is thinner than anteriorly, and this is the reason why most of the time the IV disc will try to herniate out of the posterior region. We know that it can't happen directly in the midline because of the posterior longitudinal ligament, but it can happen in a posterolateral fashion, which is what happens in most of the cases. And as the nucleus pulposus has such a high water content of 70 to 88%, as we become dehydrated, or just the weight bearing that occurs throughout the day, that is actually one of the factors that contributes to us shrinking during the day and growing a little bit, maybe 1 or 2 centimeters over the night when we're resting. The discs themselves are actually avascular, and only some superficial layers of the annulus fibrosus are innervated by recurrent branches of spinal nerves. Here's the demonstration of what it can actually look like if the nucleus pulposus herniates. Usually this will occur, as I mentioned previously, in a posterolateral direction because the annulus fibrosus, so the fibrous ring that keeps the nucleus pulposus in check and keeps it secure in between the two vertebrae, is actually thinner in the posterior direction, but because we have the posterior longitudinal ligament here, it can't go straight back, so straight posteriorly. It'll kind of squeeze out at an angle laterally, so posterolaterally, and this can then lead to compression of spinal nerve. And the vast majority of these herniations will occur either at the L4-5 level or at the L5-S1 levels. Here we have a picture of the nucleus pulposus herniating out and compressing some of the spinal nerve roots, actually starting here in the vertebral canal. And down here we have a slightly more detailed image on which we can see the L4 vertebrae and the L5 vertebrae, and we can see that the nucleus pulposus of the L4-5 IV disc is actually herniating out, and as it does so, it actually spares the root, or actually the nerve, the L4 spinal nerve, but it'll be compressing the L5 nerve and other nerves that are passing down to lower levels. See, these are the pedicles of L4, these are the pedicles of L5, and looking into here we can see that the L4 nerve will leave here, will leave through the intervertebral foramen, so the L4 spinal nerve is okay, but the L5 spinal nerve is being compressed, at least here on the left-hand side. Here we're going to have a look at some of the regional characteristics of the vertebrae, starting off at the head region. So in the cervical region we have an articulation of the vertebrae that will actually allow some flexion and extension and a little bit of lateral flexion, but it won't permit a lot of rotation, except for, well, right between the atlas and the axis, as we're going to see. So starting off here we have a foramen which is more triangular, then we have a spinous process that is bifid. We have a transverse foramina. This is important because this is where the vertebral artery passes through. and there's a little spinal nerve groove here. And then there's also going to be an uncus of the body, which is called the uncinate process. Now we're going to have a look at the first two cervical vertebrae, Atlas and Axis. And Atlas, as I said earlier, was from Greek mythology the person who was able to carry the entire weight of the world on his shoulders. Okay. Other than that, the Atlas is quite interesting. It actually does not have a body. The body of the Atlas would be represented by the axis, which is inferior to it, and the body would actually be the dens. Other than that, you can see that the Atlas is, most of it is actually just a little bony ring. Okay. And the bony ring is comprised of these two lateral masses here, which are then interconnected by anterior and posterior arches. Now, these lateral masses have these facets, these articular facets, which are going to be the receptacles for the occipital condyles of the skull, so of the cranium. You can see it also has this transverse foramen on each side in the transverse process. Also, the Atlas does not have any spine, it just has a little posterior tubercle here. Okay. If we would look at the underside of the Atlas, we can see here are the inferior articular facets for the articulation with the axis, which is sitting directly underneath or directly below the Atlas. So this here is a slightly posterior superior view, so we can imagine that the dens would then be articulating together with the anterior arch here of the Atlas. So now that we've seen the basic components of the Atlas and the Axis, we can also appreciate that there are two sets of craniovertebral joints. There are these ellipsoid atlanto-occipital joints, which will allow flexion and extension of the head, so the nodding of yes, for instance, and a little bit of lateral flexion. So this joint occurs between the Atlas and the cranium, the occipital condyles specifically. And then we also have the atlanto-axial joints, so the joints between the Atlas and the Axis, and actually there are three sets of joints between these two vertebrae. The two lateral atlanto-axial joints are going to be occurring between the superior and inferior articular facets that are occurring between these two vertebrae, which will allow gliding motions. And then there's the median atlantoaxial joint, which is formed by the articulation of the dens and the anterior arch of the Atlas and the transverse ligament of the Atlas. So as you can imagine, this joint is not going to allow very much motion other than just rotation or pivoting, so that will be, for instance, occurring when you shake your head no. So the skull and the Atlas will actually move together as one unit, and the axis of rotation is going to be the dens of the axis here. So the transverse ligament of the Atlas is very important because together with the anterior arch of the Atlas, it will form this bony or fibrous ring that keeps the dens pushed against the anterior arch of the Atlas. And in doing so, it'll make sure that the dens stays in place and that it actually can't slip posteriorly, because if that would happen, the dens would actually be encroaching on the space where we have the spinal cord. Because the Atlas is a bony ring, you can imagine that if you have a strong vertical force that is transmitted straight down, like for instance, as it can happen if an individual dives into a shallow pool, this strong force is going to make these two lateral masses separate to the left and right. What happens is that then you will fracture the anterior and posterior arch of the Atlas and laterally displace these two lateral masses. That in itself doesn't really mean that you're going to damage the spinal cord. As you can see here in figure D, you can see the spinal cord is here, and the reason for this is because you actually make the space bigger by displacing these lateral masses to the side. So as you can see here in this enlarged image, you have these lateral masses. This is a Jefferson or burst fracture. Here's the anterior, there's the posterior arch, and so in here is actually the dens of the axis. And if in addition to fracturing the anterior and posterior arch, you are also to rupture the transverse ligament, then you could actually have the case where the spinal cord may be in danger of being compressed against the dens. And down here is a CT reconstruction of said Jefferson or burst fracture, where you can see that the anterior arch here has been displaced, is coming outside, forwards, and the lateral masses have been laterally displaced. And of course we can also fracture our axis, and the example here is called a hangman's fracture. So what happens here is that we fracture the so-called pars interarticularis, indicated here, or also indicated here. The pars interarticularis, or also pars in short, is exactly that part of the vertebrae which is located between the superior and the inferior articular processes of this facet joint. And as indicated in this image here, the cause for this is severe hyperextension of the head on the neck. It is also possible to rupture the transverse ligament of the atlas. We've previously discussed how the transverse ligament can also be ruptured in case of a Jefferson or burst fracture. Here we have an example of what happens if you actually just rupture the transverse ligament of the atlas itself. So in an extreme case, if you have a look at this image here from the left lateral aspect, you can see that with a ruptured transverse ligament of the atlas, you set free the atlas and the dens, and so you can slide backwards here, slide posteriorly, and compress the spinal cord between the posterior arch of C1 and the dens. It is also possible to fracture the dens and keep the transverse ligament of the atlas intact. So in that case you would have the dens held fixed against the anterior arch of the atlas, which would then allow the atlas and the dens to move together as a unit. Interestingly, some patients that have anterior displacement of the atlas might be quite asymptomatic. And the reason for this is Steele's rule of thirds. Steele's rule of thirds tells us that a third of the diameter of the atlas ring is occupied by the dens, a third is occupied by the spinal cord, and the remaining third is occupied by fluid-filled space. So we can displace the atlas to a certain degree, but if we displace it more than a third, then we will become symptomatic, because odds are that we will compress the spinal cord. Moving on, we have 12 thoracic vertebrae. These vertebrae are each associated with a pair of ribs. This is why we have on the transverse processes, we have this little costal facet for the articulation with the tubercle of the rib. On the vertebrae themselves, you can see that they will have an inferior and a superior costal facet for the articulation with the head of the rib. The vertebral foramen is much rounder than we have seen in the cervical region. The vertebral body itself is much more heart-shaped. And the spinous processes are really long, and they overlap with the adjacent inferior vertebrae. And because the articular processes are nearly vertical here, they will permit only rotation and maybe a little bit of lateral flexion, but they will not permit flexion and extension. Next, the lumbar vertebrae. We have 5 lumbar vertebrae, and their bodies are much more massive because they have to support the weight. The spinous processes are very short and stout. The articular processes are extending vertically, but the articular facets are orientated sagittally, so we will allow flexion and extension and lateral flexion, but will not allow rotation in the lumbar region. The mammillary bodies are also specific to the lumbar vertebrae because these also provide attachment for some of the deep back muscles. Next, we have 2 more clinical correlations called spondylolysis and spondylolisthesis. Spondylolysis is a condition where you have a separation of the pars interarticularis, which is the part of the lamina of the lumbar vertebrae which is between the 2 articular processes, so the superior and inferior articular process. If we have a look at an X-ray here, it's referred to as the Scotty dog sign, because if you have a look at the vertebrae, this is what it looks like. Here's the head, here's an ear, and in this case Scotty dog has a broken neck, and that indicates spondylolysis. And here is just a picture, a diagram of the pars interarticularis, which would then be broken. If you have this defect in a bilateral manner, so if you break both of these here, it is called spondylolisthesis. which is basically dislocation of adjacent vertebrae. So if this happens between L5 and S1, it may lead to compression of some of the lower spinal nerves. Here's an example of spondylolysis, which has led to spondylolisthesis, because here we have a bilateral fracture of the pars interarticularis of L5, and this has led to anterior displacement, as you can see on this diagram as well, of the L5 vertebral body on the S1 body, which is likely to compress the chorda equina, and this will result in lower back and also lower limb pain. Now if we have a look at some of the characteristics of the sacrum and the coccyx, the 5 sacral vertebrae have all fused together, which has resulted in it being one large, pretty much wedge-shaped bone. And between the 5 sacral foramina, you still have lines that indicate the sites of fusion. The sacral promontory is the anterior edge of the body of S1, which is an important obstetrical landmark. Up here are the articular processes for the articulation with the L5 vertebrae, and down here is the coccyx, which is a really small, also wedge-shaped bone. It has a base, superior, and then the apex down here, and that'll articulate together here with the apex of the sacrum. Now looking at the sacrum again, but looking at it from a posterior view, we can see the dorsal surface here is pretty rough, and it's actually more convex than anything else. And these sacral foramina, you have these posterior sacral foramina, 4 pairs of these here for the exit of the S1 to S4 dorsal rami. Here again are the superior articular facets for the articulation with the L5 vertebrae. And then laterally on the sides here you have the articular surfaces for the articulation with the hip bones. And the sacral canal will end inferiorly here at the sacral hiatus, which is this little gap, which is formed by the absence of the spine and the lamina of the S5 vertebrae, and sometimes S4 is missing as well. And then you have these structures here. These are called horns. Actually they're called cornu, which means horns of the sacrum and of the coccyx. They articulate with each other as well. Knowledge of the anatomy of the sacrum is important as well because of caudal epidural anesthesia. You can locate the sacral hiatus by palpation. You can feel with your finger the sacral cornua and the spine of S4 or S3, and then using that as a landmark and a guide, a needle can be introduced either directly here through the ligament that in life actually covers this opening to perform a caudal epidural anesthesia. As indicated in this image, you can also introduce a needle through other dorsal sacral foramina into the epidural space. So then you could do a so-called transsacral epidural anesthesia. These are all methods that can be used to relieve the pain during childbirth. Regarding the arterial supply of the vertebral column, in general we can say that the vertebrae are supplied by periosteal and equatorial branches of some of the major cervical and segmental arteries and their spinal branches. Parent arteries of these branches will be occurring at all levels of the vertebral column. Some of the main arteries that are apparent are here posterior and anterior spinal arteries. And then there are also segmental medullary arteries and radicular arteries that go to the roots. One of the most important and most well known arteries is called the great anterior segmental medullary artery. It also has a different name, which is the Artery of Adamkiewicz. And it's very important because this is the supply to the lumbosacral region and the lumbosacral enlargement of the spinal cord. This artery, most of the time, about 65% of the time, will arise on the left side, and it usually arises from a lower intercostal or upper lumbar artery. The Artery of Adamkiewicz especially is very important because if this becomes occluded, it leads to ischemia of the spinal cord. And ischemia of the spinal cord can cause muscle weakness and irreversible paralysis. Some reasons for this could be, for instance, fractures or dislocations, so we could say traumatic injuries, but also obstructive arterial disease like atherosclerosis are common causes of ischemia. It is also possible, though, that we are dealing with an iatrogenic injury, which would mean that it is an injury that is actually caused by a physician. Sometimes the aorta has to be clamped, has to be occluded during surgery, for instance for the repair of an abdominal aortic aneurysm. So in that case, if we occlude the aorta, all neurons with axons that are distal to the site of the ischemia will also be dying. Also, when you have a drop of the systemic blood pressure for several minutes, the reduction of the blood flow to the anterior spinal artery that supplies the mid-thoracic region of the spinal cord can actually lead to the loss of sensation and voluntary movement in all the areas supplied by the affected level of the spinal cord. Now for some more clinical correlations. Fracture of the dens. Interestingly enough, the transverse ligament of the atlas is actually stronger than the dens of the axis. Nearly half of the fractures of the axis are actually fractures of the dens. So here's our dens, here's the body of the axis, and the arrows indicate the fracture. You can either have the fracture where just the dend itself breaks off, or you can have a fracture as occurring here, which includes some of the body of the axis. It's also depicted on this coronal CT scan here. You can see the dens, and you can see a fracture line here and a separation of the dens from the remaining body of the axis. Fractures such as this one here, where you can see that actually just the dens has broken off right there where it's attached to the base or to the body of the axis here, these actually don't heal very well at all, because the transverse ligament of the atlas can become intersposed between these two fragments. And as the broken off piece of the dens here doesn't have a blood supply any longer, you will get avascular necrosis. On the other hand, if you break off a little more, as depicted in this figure, for instance here in B, here's some of the vertebral body just inferior to the dens has also broken off. With it, this usually heals more readily than the other fragments, because here you still have a blood supply that functions in both of the involved pieces of bone. It is also easier to dislocate cervical vertebrae than to fracture them, and if this happens without too much displacement of the vertebrae towards each other, like in A and in B, that can actually happen without damage to the spinal cord. But if you have severe dislocations like here in C and in D, then you can actually have injury to the spinal cord. Here in figure E we have a pretty severe case. You see a pretty strong anterior displacement of this vertebrae versus the inferior vertebrae. And over here in figures F and G we have example of a more serious case, where you can see over here in figure F, you can see that the spinal cord is being compressed, and you can actually even see, if you look closely here, that this vertebrae where the blackening occurs here has obviously been crushed anteriorly. Another injury that might occur, especially in a football tackle, such as here, if you have a head-on tackle, you might actually rupture an IV disc. In this case, it happens because of severe hyperflexion of the cervical region. And one difference that we have here in the cervical region as compared to the lumbar region, here we have the discs in the middle, so they're centrally placed. Okay, so if the nucleus pulposus will herniate out, it will actually compress the nerve exiting at the same level, other than in the lumbar region. But remember that the cervical nerves will exit above the vertebrae of the same number. So if we would rupture, as in this example here, the C5, C6 disc, we would actually be compressing the C6 spinal nerve. Here's the summary for today's lecture. Remember that we have the vertebrae specialized by region, and they increase in size from C1 to L5 so that they can support the increasing body weight. Also, remember Steele's rule of thirds. This is the rule that explains why some patients that have an anterior displacement of the atlas might be rather asymptomatic until they have a large degree of movement. Also, the vertebral column protects the spinal cord and its coverings, and the roots of the spinal nerves. Beginning with the T1 spinal nerve, the spinal nerves will emerge inferior to their respective vertebrae. The IV discs act as shock absorbers and allow movement. Usually, an IV disc will herniate in the lumbar region. That will lead to compression of the nerve root inferior to the herniated disc. There are several ligaments that give the vertebral column additional support and prevent excessive or damaging movement. Our vertebrae are supplied by periosteal and equatorial branches of the major cervical and segmental arteries. Ischemia due to traumatic or iatrogenic injury can cause muscle weakness or paralysis, which may be permanent. Thank you very much for your attention. Please email me if you have questions.